type your expectations in the chat, and we shall be able to make a few comments about them. And yeah, that's it. Hello. So for anyone who has joined us and has had an experience with a Syncope case, you're welcome to share your experience. For those online, if you've had an experience or managed a case of Syncope, you're welcome to share your experience. You could raise your hand up and we shall give you the mic, or you just unmute. We are now 82. Please keep sharing the link and encourage your other colleagues to join. So you're all welcome to today's session. And if you've not shared the link already with your personnel, your friends, keep sharing the link and keep inviting them to join the session. My name is Sheif Semakula, and I'm a resident doing anesthesia and critical care at MOOC. And I'll be the moderator for the session. On my left is Dr. Mary, who's a seed educator and with also associated with Makerere University. And I'll give her a chance to say hello and say something about it. So.
Hello, everyone. How are you? Welcome to our session. And Sorry, I think we confused a few people. We usually do this every 2 weeks, of course, and we jumped up a week this week for various reasons. So we're very happy to have you all in these back-to-back sessions and here for this really important topic of syncope. Anyway, I'm Mary Ellen Lyon. I'm an emergency medicine doctor. I work for Siege Global Health and specifically teach in the postgraduate emergency medicine master's program at Makerere University. And my primary clinical site is at the Malago National Referral Hospital. I'm happy to be here today and look forward, hopefully, to an interactive session where people feel very free to jump in with any questions they have.
So the other expert is Professor Neil Scolding. If you're online, you can unmute and say a few words and send greetings to the audience.
Thank you very much indeed. I hope you can hear me. It's a great pleasure to join you. So I'm Neil Scolding. I'm a professor of neurology in the UK and a visiting professor of medicine at Gulu University and working at St Mary's Lachore Hospital and also the Referral Hospital. And I'm looking forward to the session. Thank you for joining us, everyone. Thank
you, Prof. Then the last expert is Miss Dorothee, who's a critical care nurse. And she hasn't joined us yet, but we shall be introducing her further in the session. So next on the program, we shall be having the pre-test, and we shall also pick a few people from the audience to tell us about their expectations for this session. Anyone from the people online, if you've had an experience with a syncope patient or a case of syncope, you're free to unmute and tell us about your experience. And you can also tell us about the expectations you have from today. The session is about syncope, the causes, assessment, management, and nursing care. So anyone online that would like to share an experience, you're welcome to unmute. The pretest is available, so you can start answering. And for those that would like to let us know about their expectations, you can type them in the Q&A.
If anyone would care to raise their hand and let us know if there's anything in particular you hope to hear out of today's session before we get started. Otherwise, we'll get going with our case presentation once the pre-test is finished.
Jared Hambo, Pule, you can go ahead and ask. Jared Hambo.
Well, yes, I hope I can be heard.
Yes, you're audible.
Okay, yes. I just wanted to know in the discussion I wanted if there is any difference in the approach to management of syncope in children and adults. In other words, the pediatric and then the adult population. I would love for it to be spelled out clearly if there is any difference in the approach. Thank you.
It's much less common in pediatric patients. There's no specifically different approach that I can think of. As we're going to talk about, the most immediate thing that we want to do is try to figure out the cause of it, right? What was the cause of the loss of consciousness? And some causes are more or less common in pediatric versus adult patients. But the general idea of figuring out the cause and then treating the underlying mechanism is the same no matter whether it's a pediatric or an adult patient. And we'll get into some of those causes and what to do about them as we go along. Good question.
Ms. Dorothee, you're welcome. You can go ahead and unmute and introduce yourself, please. Miss Dorothee, can you hear me?
Good afternoon. Am I audible?
Yes, you are.
All right. Good afternoon, everyone. My name is Dorothee. I'm a seed educator. I'm based in Arua, Muni University. My specialties are in, sorry, I don't have light right now where I am, so my video might be very dark. Power just went off like 5 minutes, like 2 minutes ago. So my specialty are in critical care nursing, and also right now I'm both in the ICU and in emergency unit. I'm helping at the Arua Regional Hospital and also lecturing at Muni University on the graduate nursing students. All right.
Thank you,
Thank you
Ms.
so much.
Dorothee. We are happy to have you today. Question number one, the poll, which test is not routinely indicated in a patient with a classical history of a syncope attack? Option A was ECG, tilt table test, CT scan, and ambulatory ECG monitoring. 10% of the audience chose option A, 34 went for B, 36 went for C, and 20 went for option D. As the session goes on, we shall find out which is the best, which is the actual true answer. 10% of the audience went for the ECG, 34% went for the tilt table test, 36% went for CT scan, and 20% went for the ambulatory ECG monitoring. Then question 2 is, which of the following does not indicate a high risk feature in the history of a syncope event? Option A is associated with a new onset chest discomfort or breathlessness. And 24% people of the audience chose that. And option B is pre-syncope features of pallor, sweating, and nausea. And 88% of the audience chose that. Then option C is sudden onset of palpitations soon followed by syncope, and 7% chose that. D is occurs after prolonged standing or in crowded or hot places. 61% of the audience chose that. Then question 3 is which of the following is false? A is exercise-induced syncope does not require investigation, as it is nearly always a variant of a benign vasovagal syncope, and 39% of the audience chose that. Option B is vagovagal syncope describes loss of consciousness associated with the reflex vasodilatation and bradycardia. 8% of the audience chose that. And then option C is vagovagal syncope is the commonest form of syncope. That was a choice for 9% of the audience. Then option D is recurrent syncope is more common than epilepsy. And the majority of the audience went for that. That is at 45%. The next item on the agenda is I will invite Dr. Lwanga Thomas, who's an intern doctor at St. Joseph Hospital, Kitovu, to take us through the patient case presentation. Dr. Lwanga Timothy, you can share your screen, please.
Thank you very much.
You go ahead and share your screen, please.
Can you confirm that you can see my screen?
Yes, I can see your screen.
So my name is Lwanga Timothy, and I'm a medical intern at St. Joseph's Hospital, Kitovu, and presenting a case of a 72-year-old male who came in with a sudden loss of consciousness. So the patient was a 72-year-old male, a non-DM on insulin, and also non-HTN on medication, brought in with a history of loss of consciousness for about 20 minutes. The patient reportedly collapsed while he was teaching and hit his head on a desk. Then the patient regained consciousness while on the way to the hospital. So in the emergency assessment and management, we did the ABCDE, the airway and the C-spine. The patient was able to support the neck, and the air was patent without any secretions. The patient was also able to speak, and there was no neck tenderness. So here we did not use, there was no need for a cervical collar since there was no neck tenderness. The patient was able to talk. There are no features suggestive of trauma to the cervical spine. Then breathing, the patient had a respiratory rate of 16 breaths per minute, saturating at 95% on room air. The chest was of normal shape, rising bilaterally with respiration, and there was equal air entry bilaterally with vesicular breath sounds and no added sounds. Assessment of the circulation, the peripheries were warm, a capillary fill of less than 2. However, the patient had a bradycardia of 41 beats per minute and a blood pressure of 60 over 43 millimeters of mercury, and had mild pallor. So for this, we connected two large bore cannulae, then started infusion of IV fluids. Then we also acquired samples for the emergency investigation, CBC, electrolytes, and RFTs. And we also checked the random blood sugar at that moment, and it was 24.1 millimoles per liter. So assessment of disability, the patient had a GCS score of 14/15 with eye-opening 4, verbal scoring 4, patient was confused, and a motor of 6. The pupils were equally reactive to light. He had normal reflexes, normal tone and bulk with no focal neurological deficits. So because of the random blood sugar that was 24.1, in our management, we consider starting this patient on insulin. In exposure, the patient had a hematoma on the right parietal area measuring about 5 centimeters diameter, and it was tender. We gave the patient analgesia, IV paracetamol, and also considered doing non-contrasted CT for the patient. So in the secondary survey, we found that the patient's signs and symptoms included the sudden loss of consciousness. The patient reported that prior to the loss of consciousness, he felt some lightheadedness, blurring of vision prior to the collapse. He also had palpitations and easy fatigability. However, he didn't have chest pain, there was no DIB, there was no orthopnea or PND, there was no reported event of venous convulsions, and no headache. The allergies, the patient did not report any food or drug allergies or use of any drugs that they are allergic to. Medications, we found out that the patient had been on mixed insulin, 25 pre-breakfast and 15 pre-supper. Was also taking metformin 1 gram BD. For the hypertension, the patient had been on losartan H and nebivolol 20 milligrams. Then was also on atorvastatin and pregabalin. Past medical history, he was non-DM and non-HTN. This was the index episode of the sudden loss of consciousness. His prior admission had been in January this year. He had been managed for diabetic foot and had his 4th and 5th toes of the left limb amputated. At the last meal, the patient reported that he had had his breakfast. The events surrounding the scenario, he hit his head on a desk during the collapse. So from our problem list, the patient's problems included the sudden loss of consciousness, palpitation, dehydration, hypotension with a bradycardia, hyperglycemia because the RBS was 24.1, and we also queried head trauma. So the quick investigations we were able to get, the RBS was 24.1. Urinalysis, we did a quick one to make sure the patient was not in DKA. So there were proteins in urine, glucose plus. However, there were no ketones, the leukocyte esterase was also nil. There was no blood, and the pH was 6.0. And the CBC, the white cell count, the total and the differential were in normal range. Patient had an HB of 11.4 and the normal platelet count. And our electrolytes were also within normal range, both the sodium and potassium. The creatinine was 1.1, just slightly elevated by around 0.1 according to our local lab. Then later on, we were able to acquire an ECG for the patient, which showed a sinus bradycardia and first degree AV block. Then the CT that was done showed there was no more brain parenchyma and no intracranial hemorrhage. So in the management of the patient from the emergency ward, put 2 large bowel cannula on the patient and we started fluids, normal saline. Because of the hyperglycemia, and we're not sure at that moment if the patient had taken his pre-breakfast dose of insulin. So we started on a sliding scale with 20 international units of insulin. Then we did the sliding scale until the patient's blood sugars were normalized. Then, so in the follow-up, the patient's BPs were able to pick up and his DCS improved. And also the long-term plan, his antihypertensives were changed. We removed the nebivolol because from our assessment, we are thinking probably the hypertension could have been the primary cause of the syncope, and the patient was taking a beta blocker, which could have precipitated an AV block. So we stopped the nebivolol and the patient on Rosetal alone. So the patient was discharged after 2 days of observation, and he was in a good state. Yes, thank you.
Charango, are you still there? Dr. Ranga,
Yes, please.
please go ahead.
Yes, I'd come to the end of the presentation with the treatment and follow-up of the patient. I was saying the patient was discharged after 2 days on the ward. We managed him. We were thinking the primary cause of our syncope was the hypertension that was secondary to the beta blocker that he had been taking. So we changed his antihypertensives from the losartan H and nebivolol to losartan H alone. Thank you.
Thank you, Dr. Ranga Thomas, for the brilliant presentation. We have Peter, Mr. Peter asking in the chat, why 20 international units? Maybe you'd respond to that and then we move on to the next. Ranga? Dr. Ranga, can you hear me?
So we started the patient on 20 international units of insulin in reference to the local protocols of our hospital here. Management of hyperglycemia, we use a sliding scale. If a patient comes in with blood sugars that are above 24, above 20, we start with 20 international units of soluble insulin, and we give 500 mils of normal saline. So for this patient, we were managing as it was not hypoglycemia but hyperglycemia, and we confirmed there was no DKA because we did not find ketones in the urine. Of course, for the investigations we can do to rule out DKAs, the urine ketones, since we cannot do the blood ketones, and from the presentation, the patient did not have the typical features suggestive of DKA, like the Kussmaul breathing. Yes,
All right, thank you for that. Then we shall take two more questions from the chat. Angela Tumusime is asking, what's the RBS at discharge? What was the RBS at discharge?
So the RBS at discharge, I can't really remember very well, but we had stabilized the patient's blood sugars and we fixed them back on the insulin. As they were taking their insulin with 25 international units pre-breakfast and 15 international units pre-supper. Then they also continued with a metformin.
All right, thank you. Then lastly, Ronald Alema is asking, how did you arrive at the fluids of 4 liters?
Yes. So we gave a start of 1 liter in 1 hour because of the pressure that was less than 90. Then the other 3 liters were a calculation of the maintenance fluid.
All right, thank you. So the other questions in the chat will be answered directly, and for those that have not been answered, we shall take them at the end of the session. So I would like to recognize Dr. Kizito Prisca, who is the head of the emergency department and Mbarara at Mbarara University. Dr. Kizito Prisca, please say a word and you could come up and introduce yourself to the team. Dr. Kizito.
Thank you very much. Thank you very much, Thomas or Ibrahim. I'm Prisca Kizito, as introduced, and I'm the head of Department Emergency Medicine, Mbarara University, and I also serve within the hospital as the emergency physician attending. And I'll be answering a few chat questions, and if there are any for the experts, please throw them in the Q&A section for later. Thank you very much. Enjoy the session.
Thank you. We're happy to have you too. So next on the agenda, we shall be having Dr. Mary Helen telling us about the assessment, investigation, and the emergency management of a case of syncope.
All right. Hello again, everyone. Let me just get my slides up here. So, yeah. All right. So I'm using some slides today that are based on ones from the African Federation for Emergency Medicine. I've changed them a fair amount, but I wanted to keep their logo here and to actually talk about these a bit because it's such a critical resource, and I wanted to make sure that all of our attendees are aware of it. The African Federation for Emergency Medicine is exactly what it sounds like. It's a coalition of all the emergency departments that are helping as emergency medicine grows and spreads as a specialty here, most especially in sub-Saharan Africa. And they have a great website and a section of their website specifically devoted for resources to be used by all levels of healthcare providers. And I just wanted to spotlight that because it's such a critical resource. And I just wanted to show, if I could, I'm going to see if I can make this happen in real time here. Get this over. I don't think it's going to let, is it not going to let me extend? Let me see if I can try something else here really quickly. Yep. All right. I just want to show, if I just hit AFAM resources, and you can go there. to their resources page, and it's such a great resource to use that I just wanted people to see. We go to the resources tab there, and then there's a clinical section, there's a nursing section as well, all kinds of great stuff. And under clinical, if you go under, there's a curriculum there, there's a presentation bank there that has these sort of presentation slideshows on all kinds of topics there, right? And they're wonderful things. They're not image heavy, so they're not data heavy. You can download them without using too much data. And you can also, you know, if you're somewhere we have Wi-Fi, just bring them all down onto your computer sometime when you happen to be around having a Wi-Fi or something, and then they make an amazing resource. So I just wanted to spend a bit of time today just, you know, highlighting that before we get on with our immediate priority today. Okay, so today we're talking about syncope, which is specifically a self-limited loss of consciousness. So you lose consciousness. It's associated with a loss of postural tone. People most often either slump over or fall to the ground, and then you spontaneously return to baseline, right? So you have to spontaneously wake up, and when you wake up, you have to be at your baseline, not confused, not having, you know, any kind of neurologic deficits. You lost consciousness, usually lost some postural tone at the time, and then spontaneously came right back to where you were, to your baseline. And pre-syncope is a near loss of consciousness. It's when you feel like you almost faint, almost lose consciousness, but don't quite. And we manage that much the same way as syncope. So before I get into the actual, like, say, emergency department, I work in the emergency department. Before I get into the management and diagnosis and management and the emergency department, I want to talk very briefly just about some of the causes and the differential, because I don't think the questions that I'm going to recommend that you ask or the will make sense until we talk a bit about the differential. And sorry, I lost it there. No. So the big thing with the loss of consciousness, the main differential is, was this syncope or a seizure, right? That is the first big question to be thinking about. And seizure is associated with some other things. For one thing, a true epileptic seizure, you're not going to come immediately back to baseline. With a seizure, you're going to come up a bit slowly. You're likely to have a post-ictal phase, which is going to be where you have a period of confusion from which you gradually return to your baseline. As opposed to, as I say, with syncope, where you're going to have a spontaneous return right back to your baseline, right? So I'm going to spend a little bit of time today talking about the differential, the different kinds of syncope, and then our neurologic, our true expert, if you will, Professor Scolding, is going to go much more in depth about it. Going to cover much the same ground, but a little bit more in depth. So I just want to touch on it lightly here so that the diagnosis and management will make sense. And then when we get to Professor Scolding, you'll go back around hearing it a second time to let it sink in a little bit more and dig a little bit deeper, okay? So for now, our first question is, when this person comes in and they lost consciousness, woke up on the ground, syncope or seizure, not that difficult to distinguish if it's a true seizure, because a true seizure will have a post-ictal period where they have to come back to us slowly after a period of confusion. On the other hand, it can be very confusing because some convulsions, some kind of shaking can be very common even after true syncope. So it's not at all uncommon that witnesses will say, he had a seizure. Why do you think he had a seizure? Well, he was shaking. That alone does not necessarily mean it was a true seizure, because some convulsions are common even after true syncope. Anything that can bring even a transient hypoxia or low oxygen can cause some shakiness. So a seizure, you're going to have post-event confusion. So one of the questions I often ask people is, when you woke up, did you know who you were and where you were right away? And the patient says yes. If they're like, I was at a restaurant, I was walking to my car, I woke up on the carpet. Did you know who you were and where you were right away? If they did, that's not a seizure, right? Tongue biting, a history, obviously, of seizures, or incontinence. If there was like urinary or fecal incontinence, that's very suggestive of a seizure. But this idea that anyone who shakes or has any kind of convulsion has a seizure is kind of a common pitfall in this realm. Other things that it might be that aren't syncope, that are not a true syncope episode, are an arrhythmia of some sort, some kind of cardiac dysrhythmia, congestive heart failure, or there can be metabolic causes. You can be hypoxic, hypoglycemic, or hypocapnic. You can be intoxicated with any number of things, whether that's alcohol intoxication or some recreational drug that you took. And there are also some psychogenic causes. Much like with, I don't know if you all have much experience with seizures, people who come in with what seems to be a classic seizure phenomenon. There are true epileptic seizures, which are caused by what we think of as a sort of an electrical storm in the brain. And then there are psychogenic seizures, psychogenic non-epileptic seizures, which are caused by some psychogenic condition, not involve an actual electric cause of the seizure. You can also have sort of psychogenic causes of syncope, is also on the differential. So one of the frameworks that we use, and this is not the only one, like everything else in medicine, I don't know if you've noticed, like if people talk about, oh, the 4 classic causes, the 4 classic types of shock, or somebody else talks about the 5 types of shock, or there's a bunch of different ways to put us medical syndromes into buckets, right? So if you just Google types of syncope, you're going to get one website that talks about the 3 types of syncope, and another website talks about the 5 or the 4. There's different ways. Find one that works for you. This is just one way, one framework of thinking of it that's fairly simple, which is good because I'm an emergency medicine doctor and I like things that are fast and that are simple and that get quickly to the how afraid do I need to be place, right? So this is a framework that I think of, which is the reflex, or we think of this is sort of neurally, nerve-mediated syncope. There's neurovascular, more connected to the vascular system, or cardiac syncope, yeah? That's just sort of some ways to look at it. So this more neurally, nerve-mediated or reflex syncope, we don't have to get really wrapped up in all those blue boxes, but in general, we think of a vasovagal syncope, a situational syncope, and then there's something called carotid sinus hypersensitivity. And like I say, we'll talk more about these later and can certainly answer any questions that you have. But in general, with these, there's something that activates the sympathetic nervous system, and that causes a response in the brain, which the brain then signals the vagal nervous system, or just backs down the sympathetic system. You end up getting a slow heart rate. Maybe your blood vessels dilate. You get hypotense. Temporarily then getting less perfusion to your brain, and you have a syncopal episode, yeah? And so that is what we call reflex or neurally mediated syncope. And that can be caused by any number of reasons. It is, in my practice, it's the most common kind that we see, and it has an excellent prognosis. It's just when, because of some situation that arose, you have a transient drop in your heart rate, dilation of your blood vessels, and you get this transient drop in your blood pressure, right? If it's vasovagal, that can happen from emotional distress, from a painful stimuli. I know I don't have to tell the nurses on here, certainly, that a lot of people, when they get a shot, can sometimes have a vasovagal response, right? When I was in first grade, we took a little field trip to a veterinary office, and they showed us a dog that had just had surgery, and he had stitches on his stomach. And I turned to my best friend to say, how cool is that? And she was out on the floor. She'd taken one look at the dried blood, had a vasovagal episode, not that I knew that at the time, but she had just completely dropped to the ground, having fainted or had a syncopal episode. She woke up as soon as she hit the ground because it was a simple vasovagal response, right? So high emotion or pain can cause a vasovagal response. There's also situational reflex. So it can happen with micturition, when you void urine from your body, when you defecate. This can also happen. That happens to us sometimes in the emergency department. We'll put a patient on a bedpan, for instance, when they need to defecate, and their blood pressure will just drop. And the people I've had people call a cardiac arrest code on someone just because their blood pressure and their heart rate just bottomed out while they were pooping. It can happen from something as simple as a coughing spell, or sometimes postprandially, after you eat a big meal, your brain decides, hey, we need a lot of extra blood down there in the digestive system, and particularly in the elderly or people with a history of high blood pressure who might have very stiff arteries. The blood pressure doesn't adjust very well. Blood goes to your gut, drops from your brain, and you can have a post-meal syncope. That's situational. And then the last is a more rare but very interesting carotid sinus hypersensitivity. We might remember from our anatomy classes, our carotid arteries have baroreceptors or pressure receptors in there. And when they feel high blood pressure, they tell the brain, hey, dilate, we need to bring the blood pressure down a little bit. Some people have very, very sensitive carotid sinus baroreceptors, and even turning their head can cause extra pressure on the carotid artery. The brain can say, the blood pressure just went up, and they can have a syncopal episode. So that's a known phenomenon as well. So those are our reflex syncopes. Then we have our neurovascular bucket. And this is when, for whatever reason, again, the brain doesn't get enough oxygen, doesn't get enough blood temporarily. That can be an autonomic failure, like our automatic nervous system just is not working well. It can be because you've had a volume loss. You know, whether you're dehydrated for whatever reason, it could be even a blood loss from a trauma, something like that. But for whatever reason, you have that loss of perfusion to your brain, and you end up in a syncopal episode. Yeah, that can be, as I say, the dehydration. It can be something like an ectopic pregnancy, right? So that's someone who's hemorrhaging on the inside. You can't see it, which means you won't find it if you don't think of it, right? And similarly with a GI bleed, that you may see, you're more likely to see, they may be losing some blood per rectum, but you're not even going to check down there if you don't think about it, right? So these are some important things to consider with the possibility of a neurovascular syncope episode. And then the last one, as you can imagine, is the one that we are sort of most immediately worried about, though we certainly need to worry about some of the more concerning neurovascular, like a GI bleed, especially in the elderly, and an ectopic pregnancy, of course, which is always concerning. This is often life-threatening, and this is sort of in that can't miss diagnosis. People always tell us as emergency medicine doctors, we're like worst case scenario people, and we are. What I worry about in the emergency department are the things that I can't miss, or you might lose your life, right? If it's not a concerning reason for syncope, okay, I may or may not figure out today what caused it. What I don't want to miss is if it's a life-threatening cause, right? And these cardiac causes tend to be there. So you can have a dysrhythmia, which can go, you can have like a very low heart rate or a very high heart rate. A very, very high heart rate doesn't give the heart time to fill. and you can have a insufficient forward flow of blood just from a very high heart rate. So any dysrhythmia that puts you on the extreme of your heart rate can be very concerning. You can also have structural heart disease. You might have severe aortic stenosis is one of the most concerning causes of a syncopal episode. You can have heart failure, an acute infarct, otherwise known as a heart attack, right? Or somebody's having myocardial ischemia. Certainly, if you have a major heart attack, you might have an episode. Tamponade, when there's fluid in the sac around your heart, and there's so much fluid that you can't, that the heart can't fill, or then congenital disease. And then it can be an increase in the afterload, like your blood pressure there. If you have pulmonary hypertension, you can have the pulmonary embolism, clots in your lungs that are keeping your flow from happening, or hypertrophic cardiomyopathy. This is a very concerning, usually congenital cause of syncope that often manifests as sudden cardiac death. When you read about, and it happens all too often, unfortunately, a young, seemingly healthy athlete who just has a sudden cardiac arrest on the field of play, it's often due to previously unrecognized hypertrophic cardiomyopathy, when some part of the heart is too large and is unable to respond appropriately to that increased demand. Yeah. Okay, so I just wanted to go, as I say, very briefly over that kind of fast version of the types of syncope. So you have some idea when this patient rolls into the emergency department, what is going through my head as I'm trying to do my history and physical and decide the management and disposition, right? So the first 5 minutes often looks very much the same. Any patient that comes in, I'm going to do my airway, breathing, circulation, disability, and then the environmental circumstances. I want to get a full set of vital signs, including, if at all possible, an oxygen saturation, right? Because when this syncope is a matter of the brain didn't get the blood that it wanted, meaning it didn't get the oxygen it wanted. So I want to know, is this a continuing problem? Is this a patient who is not getting enough oxygen, or was that a transient a problem just of the perfusion? If you can get the patient on a cardiac monitor, if humanly possible, an EKG is always desirable. I know this is not it's not widespread availability of EKG, so we try to remember that we're dealing with a wide range, I know, of availability of diagnostic tools with our echo participants here, but if possible, we want an EKG. And with any, and I've said this before on echo and certainly a million other places, any form of altered mental status, we want to get a blood glucose, right? We always want to get a blood glucose, especially for hypoglycemia. Low blood sugar can be an immediate life threat, and it's one of the great mimics in life. Low blood sugar can mimic almost anything, including syncope or seizure or some of the other things on our differential. So if you can possibly get a random blood sugar, I would recommend it. Okay, with the history and physical, one of the things, so a lot of our patients, including our patient today that Dr. Lwanga was taking us through, lost consciousness and then fell to the ground. Also, there was a head strike involved as well. So anybody who comes in with a fall, whether this is somebody on an icy sidewalk in winter, whether this is someone who just slumped over in a chair, I want to know, why did they fall? And did they hurt themselves when they did fall? It seems obvious, but when somebody comes in, say from a car accident, and they've got major injuries, if you don't take a good history, you may miss the fact that that car accident happened because they were driving along and lost consciousness, if you don't ask the wife or whoever was in the car with them, right? So I always want to know, why did this patient fall, and was there trauma from the fall? So keep that in mind. Don't just focus on the reason, like syncope, and don't just focus on the trauma. If they come in with some, dramatically bleeding from the brain, bleeding from the head rather, you want to deal with that, but you also want to know, why did they fall? Did they just trip? Or were they walking along and passed out spontaneously? Yeah? Okay, so we talk about prodromes with syncope, which really just means a set of symptoms. And that can help us figure out whether or not it's syncope and what kind we think it is. So before you lost consciousness, Mr. or Ms. Patient, did you feel nauseated? Did you have tunnel vision, this sense of like, whoa, like the world was just kind of closing in on you visually? And were you diaphoretic? Did you feel really sweaty? If you had this wave of nausea and sweatiness and kind of this wonky visual things, that actually is very reassuring for a reflex or a vasovagal syncope. If you had chest pain and then passed out, that's more concerning for like an ischemic or an aortic stenosis, obviously. Dyspnea, like significant shortness of breath and then passing out, could be a sign of a pulmonary embolism. A severe headache, a sudden severe headache, like the worst headache of your life, and then passing out is concerning for us. A spontaneous, a subarachnoid hemorrhage, yeah. And then a sudden syncope with no warning, not having that like nausea, the sweatiness, the tunnel vision, just like I'm fine, and then I wake up like, wait, what happened? Is concerning for a dysrhythmia, right? You're less likely to have symptoms ahead of time if your heart is the problem. Yeah, if it's that neurally mediated autonomic system reason, you tend to feel it coming for a few seconds and then pass out. When your heart just is the problem, you tend to just go quickly. Yeah. Other history we want to talk about is, what were you doing? What were they doing when it started? Were you exercising? Had you just stood up? I almost pass out every Christmas Eve because I do things at the last minute. I sit in my parents' living room, frantically wrapping presents for like hours, and then I stand up quickly and almost pass out every time, right? Because I'm down there, I pop up so quickly, my blood pressure can't adjust, and I get that pre-syncopal feeling. I specifically want to know if this happened while the patient was sitting or lying down, I'm much more concerned. Syncope at rest. Syncope at rest. If I were to suddenly syncopize right now, sitting in this chair talking to you, or if you're lying down and you have a syncopal episode, you lose consciousness, that is a cardiac cause until proven otherwise. Right? If I'm hanging out down here on the floor and I pop up suddenly, then that might well be my blood pressure just couldn't catch up and I had a few moments of hypoperfusion in my brain. But if I'm sitting in a car or sitting here talking to you now and I lose consciousness, that is very concerning for a cardiac cause. That would suggest that for some reason my heart suddenly couldn't get enough blood to my brain. And I need to know, as a doctor, I need to know why that was, right? So syncope at rest means be afraid. Figure out what's going on, okay? The other thing, medications, do you have new medications, a change in medications? Did they go to a traditional healer and take some kind of herbal something? Certain medications are known to have, to prolong the QTC on an EKG and can lead to cardiac problems. So anything doing with medications. Obviously, any history of heart problems, any family history of sudden cardiac death. One of the most important questions you can ask a patient is, do you have any family history of sudden death at a young age, even a drowning or something? Because a drowning may have happened because of a sudden cardiac situation, right? So always ask syncopal patients, is there any family history of sudden death of any kind? Yeah. And then the last one here on this slide is post-syncope symptoms. So, okay, this is what happened beforehand, and then you passed out and you woke up. Did you wake up with a terrible headache? Did you wake up clutching your chest in pain? Are you nauseated? Are you short of breath? Are you having any symptoms afterward? In our more classic syncope, due to the less concerning reasons, patients are not usually symptomatic afterwards. If they bonk their head, they may have a headache, but they don't usually wake up clutching their head from some terrible pain. Yeah. So these are some of the things in terms of some of the physical exam. Obviously, you want to get vital signs and make sure that the blood pressure and the pulse are the same on both upper extremities. You want to do a heart exam, check the neck, check the rectum, orally and abdominally. And why? We won't go over all of these things now, but I know we post these slides later, so you can go through and look at all of this now. But these are the different these are the reasons why you're looking at these things. A thorough physical exam, and if anything jumps out at you, if you hear something in the neck, if you notice in the mouth that they bit their tongue, right? If they have abdominal tenderness, any of these things concern you for possible reasons for that syncope other than just that transient hypotension. In terms of investigations, as you can imagine, it very much depends on the clinical picture. As I say, if you can get an EKG, just do it. If you have a female patient, let's find out if they're pregnant if we can. A hematocrit or a hemoglobin to let us know, was this a matter of, is it anemia, that sort of thing. Electrolytes can be one of the causes that we already talked about. And if we have concern for the cardiac reasons, getting cardiac enzymes. I know that a lot of these things aren't available in places. So what our focus on here today is, I think, trying to figure out whether this falls into a bucket I need to be worried about. If I need to be worried about, how much of the workup can I do at this facility where I'm working? Or is this a patient I need to transfer to a higher level of care or someplace that can do an EKG, that can do a troponin or something like that, right? So that's, I think, the focus for us here today is scary syncope, not scary syncope. And then figuring out if it's scary, can I handle it where I am, or do I need to push them down the road to someplace with a bit more ability? Yeah. Okay, and then finally, with the management, obviously, again, depends on what kind of syncope do you think you've got, and what are you able to do at your facility? Is this a healthcare center too, or are you hanging out in a regional referral hospital or a national referral hospital? Again, the first thing you want to do is figure out what you've got here. Is it syncope? Is it seizure? What kind of syncope? If you think it's something as simple as dehydration, a fluid bolus, unless you have reason to think they have massive congestive heart failure, try a little bit of fluid, see where that gets you. Basing things on look at your vital signs and see if you can address what's in front of you, even something as simple as a fluid bolus or some dextrose. If you're concerned for the glucose, even if you can't check it, give a little dextrose, see if that helps us. Some of the things that you might want to think about either testing further or pushing down the road to somebody who can test further. If you've got an EKG and it's abnormal, no brainer. Get that person to a cardiologist or down the road to somebody who can figure it out. If they have a concerning cardiac history and they lost consciousness, they need to get to a specialist, right? If their blood pressure if they're hypotense when they get to you, if they're still hypotense, that we're going to worry about that because they should have come back to their baseline, right? If they're significantly anemic, if they're elderly with significant comorbidities, or if they are pregnant, we need to look a little bit more closely. If they say yes to the question about sudden family death, well, I did have a cousin who dropped dead playing basketball, or I have had 2 uncles who drowned. Push them down the road, right? And then the exertional syncope. If this is a young, healthy person who was playing football and passed out on the field, that is not somebody who's going to get a little bit of fluid and go home. That patient needs to be evaluated for a possible undiagnosed congenital heart disease, right? If they're exercising and pass out, somebody needs to take a look at that heart with an ultrasound. All right, in terms of our disposition, and then I'll let you go, admit or transfer to a higher level care if they've got heart problems. If you're worried they might have heart problems, including if they passed out while they were sitting or lying down, right? If they were exercising, if they had syncope at rest, or some concerning family history, or those symptoms that make you worry about the cardiac cause, if you had an EKG and there's something on it, that patient needs to be admitted or transferred for higher level of care. the patients that you can probably discharge to see to follow up with their doctor tomorrow. If they don't have any kind of concerning history, if they had a very classic case, if they said, yeah, I was just like, I just, eaten at the restaurant, and I stood up and I felt really nauseated and sweaty, and then I woke up on the floor of the restaurant. That is a that's a good cause. Postprandial, it's a classic prodrome, right? And they woke up and knew who they were and where they were. That is a patient that you can send home to follow up, right? If they're very young and healthy and nothing concerning, and if you have, as I say, a clear non-threatening cause, then you can go with that. Sorry. And then the last thing here, we're not going to talk about this today, but I know people are always interested in going over the slides later. Here from uptodate.com is a very nice algorithm. Not going to go over it right now. I just wanted it to be there in the slides so you know that you have that resource after this. And then also included in these slides, just so you know you have later, I have the AFIM also has for Syncope a rapid assessment protocol. Again, we're not going to do it here, but I have that connected to these slides, and it's going to be a great resource if anybody wants to look at it later after today's session. That's it from me. I'm happy to, not sure what we're doing, but I'm happy to either take questions or perhaps move along, and we'll take a bunch of questions from all of our panelists later in the session, whatever we think best.
All right, thank you, Dr. Mary, for that brilliant presentation on the causes assessment and the emergency management of syncope. And she stressed a couple of things, including the causes, which included a neurally mediated reflex, and of which mentioned the vago, where you have a pain stimuli coming in to give you the syncope, or just emotion on a Christmas holiday and you're very excited. And then she also talked about the neurovascular syncope, which is basically you're losing so much volume, like she said, too much bleeding that causes cerebral hypoperfusion. Then lastly, she mentioned the cardiac causes of syncope, which included the dysrhythmias, whether that is the bradycardia and then the tachycardia. Then we are just taking one question from the chat, and we shall proceed. There's a question that from Tiani Dennis to Dr. Mary. Is there any time range / duration to categorize as syncope? E.g., is it still syncope if one wakes up after 24 hours?
Excellent question. It is not. If you are unconscious for 24 hours, that is what we call a coma, not syncope, right? Syncope is that transient, short-term loss of consciousness that improves once you're and you lose that postural tone, and then once you're down, you wake up spontaneously, right? You're only out for a few moments. The significant, and even when I hear about this patient that earlier that was presented to us, when I heard that they were unconscious for 20 minutes, 20 minutes doesn't sound like syncope either, but it sounds like that patient had a syncopal episode, bonked their head on the way down, and then may have been out due to a concussion. But syncope is very specifically a very short-term transient loss of consciousness that resolves spontaneously once you've lost that postural tone and your brain is able to get the perfusion that it wasn't getting. I bet you anything, Professor Scolding's going to talk about that as well.
So we go on to the next presenter. I would like to invite Professor Scolding to take us through the causes, investigation, and long-term management and complications of syncope. Professor Scolding, you're welcome.
Thank you very much indeed, and it's really nice to be here. Thank you for that, and thank you for the fantastic lecture, Dr. Makerere and Lyon, which really covers the ground brilliantly and reiterate a lot of what you've said. But as you said, repetition is an ideal way to encourage learning. And we'll see. We'll have a look at one or two things. So, syncope. What I will try and do is talk about the definition a little bit, about the prevalence and impact of syncope, about its causes, and you've heard about those already, and about the diagnosis and management, which you've also heard about. And we'll maybe go into a little bit more detail about some of the tests that are used. And then if there's time, maybe cover a couple of some of the more specific conditions. So as you've heard, and I completely agree with the definitions you've heard before, it's brief, it is self-limiting syncope. It does last less than a few minutes, although what the size of the few is, nobody is quite certain. Loss of consciousness and loss of tone, so the individual falls, and it's due to an acute global loss of cerebral circulation. And the important word there is global. Of course, a focal loss of cerebral circulation giving rise to a transient problem is a TIA. This is very much global loss of circulation. They can occur without warning. Perhaps more common though is for them to be preceded by a prodrome, which we call a pre-syncope. And again, you've heard a little bit about that already. So syncope is just one of many types, many possibilities to explain the transient loss of consciousness. I've listed some of the others there, and that's by no means a total list. And Dr. Makerere, in fact, mentioned most of these and some others as well. Perhaps the commonest part of the differential diagnosis, again, as Dr. Lyon mentioned, is epilepsy, and that's something that you have to concentrate on when you're first seeing a patient with potential syncope with transient loss of consciousness. And it is very common. And one way of looking at it is to look at it from an individual perspective. And 40% of us will have a syncopal episode at least once in our lives. Hello.
Professor?
Yeah. Professor Scolding? Yeah. Some are having a bit of difficulty hearing you. Yeah. I wonder if you're having some people having a bit of difficulty hearing you. I wonder if maybe you could just speak up a bit.
Yeah, I can do that. Is that any better?
Wonderful, wonderful.
Okay. If it might help if people muted their microphones. I'm getting some comments on theatre activity and such like. So at least 40% of us will have a syncopal episode at least once in our life. This is a very common disorder. And one thing that it's easy to forget is that it is common in the elderly, and it is a common cause of falls, otherwise unexplained falls in the elderly. And in round about 1 in 20 cases, there'll be a significant morbidity, exactly as illustrated by Dr. Lwanga's case with the head injury as the individual fell, and a minor injury in almost a third of cases. Another way of looking at the impact of syncope is the estimated hospital costs in the US at over 10 billion, roughly 1% of them admissions in some studies are due to syncope, 3% of in terms of the impact for the patient. It is, I'm afraid, often misdiagnosed as epilepsy, and that, of course, has major consequences for the patient. So the causes, and this illustrates exactly the point that Dr. Mary Ellen mentioned, the different ways of classifying it, and I've kind of running with the hair and hunting with the hands in this. I've got 2 or 4 classifications depending on how you look at it, but you can basically divide it into primarily neural driven and primarily cardiac driven. The primarily neural driven syncope, again, you can divide into 2, reflex sympathy, and we'll talk about that in more detail in a moment, and orthostatic or hypotensive primary primary hypertensive syncope, we'll talk about that too. And then the cardiac cause and structural on the other. And again, Dr. Lyon talked about these. And of course, what that doesn't include is the third category of unexplained. And in terms of proportions, around about 2/3 of all syncope are reflex sympathy or principally vasovagal syncope. About 10% are orthostatic, about 15% are cardiac, of which 10% are arrhythmias and structural heart disease, aortic stenosis or HOCM mainly, around 5%. And even after fairly intensive investigation, 10% or so of cases of syncope will be non-diagnosed. Part of the reason for the importance of distinguishing neural from cardiac syncope is the impact on the patient's life, the potential threat to the patient's life. There's a significant mortality, as this very big Framingham study published in the New England Journal 20 years ago showed a significant morbidity on follow-up and mortality, I should say, in cardiac syncope, much lower in neural syncope. So making that distinction of cardiac versus neural syncope is very important. So what about making the diagnosis? Of course, when the patient presents, they are nearly always post syncope, they've recovered. If they're not, then your management is of course rather different. The ABC that Dr. Mary Ellen mentioned, that emergency physicians is very much part of your normal working day and working life. The unconscious patient needs investigating in a slightly different way. If they've recovered, and this does appear to have been a syncopal episode, there are two questions: distinguishing syncope from syncope mimics, particularly epileptic seizures, as I mentioned, and establishing the cause of the syncopal episode, and in particular, whether it is cardiac in origin. And Dr. Merriam went over the particular features of the history, and really I can't do anything other than repeat the various things that Dr. Lyon mentioned. The circumstances of the recent event, either from the patient or from an eyewitness, are absolutely crucial. What happened before, what happened during, and what happened after the episode of loss of consciousness? Have there been previous events? And especially, has there been any kind of cardiac history? Is there a family history of cardiac disease or sudden death? These are absolutely crucial questions. The particular features that point to a syncopal episode are the presence of triggers, severe pain, hot, airless, crowded room, sight of blood. You know these different features that can trigger reflex or vasovagal epilepsy. It is very rare to happen if a patient is sitting or lying. The patient classically feels awful. The vision blacks out, the patient is very pale, they may be seen to be extremely sweaty, and all this lasts for a minute or two, no longer than that, and they lose consciousness. It is quite common for a patient with a syncopal attack to have myoclonic jerks, exactly as Dr. Lyon mentioned. This should not push you strongly towards a diagnosis of epilepsy in isolation. And it's not very common, but it can happen that a patient is incontinent as well during a syncopal episode. So that too is not a cast iron proof of epilepsy by any means, as it is unfortunately often taken to be. And then the recovery is very rapid, especially their awareness. They may feel a bit groggy and a bit nauseated, but they are not confused, and they don't have that long period of sleep that a patient with an epileptic seizure will very frequently have. So these features are very important and very valuable in helping to distinguish a syncopal episode from epilepsy. And then the examination, and again, we've been over these things already. The cardiovascular examination is absolutely crucial. An ECG, I would say, is a routine part of every syncopal patient assessment and a neurological examination. Now, I've put carotid sinus massage there in red, and in bigger red, I've put not routinely. And in many accounts of how to manage syncope patients, you will see that carotid sinus massage is recommended as a diagnostic test. It should not be done, in my opinion, at the presentation of the patient. It should only be done under very controlled conditions, preferably on a tilt table, and a bit later, well after the acute episode, with monitoring. It is a potentially dangerous test and should not be done routinely or casually. And various studies have shown that a well-taken history, a conventional physical examination, and an ECG, no other investigations will give you a presumptive diagnosis in around about a third of cases. The red flag features, which might suggest a cardiac cause and therefore might suggest the risk of sudden death, are age, the clear presence of heart disease, either historically or on examination, a family history of sudden death or cardiac death, particularly in young individuals, or an abnormal ECG. And Dr. Muriel emphasized exactly these features. And these patients need urgent cardiac assessment. They should not be simply dismissed and sent away. They're not cases of benign reflex or vasovagal syncope. And the other point is that syncope during exertion is also potentially serious, and again may suggest a cardiac cause. It doesn't necessarily. Some patients with reflex epilepsy will have an attack induced by exercise, but it's much more common that that's a triggering event in patients with cardiac syncope. And a bit like the algorithm that Dr. Muriel showed, this isn't really a slide to be talked through. There's far too much information on it, but it is a slide that will be available to you. And to my mind, very nicely summarizes the difference in the prodrome, in the event and in the recovery periods in reflex vasovagal syncope on the one hand, cardiac syncope on the far right, in the column on the far right side, and epileptic attacks in the middle. So they're possibly in the wrong order, but those are the three groups that you really want to try and distinguish, and some of the important features are summarized well, I think, in that table. So in a young patient with a single presentation, with clear situation dependency, with a normal physical examination and a normal ECG, and of course with no significant injury, and that certainly wasn't the case with the individual Dr. Lwanga presented, the history and physical examination is enough, provided again they're in a low risk occupation. These individuals probably can be safely discharged from the emergency department. What about later on? And what about other diagnostic tests when you're not absolutely certain? There are three groups of investigations that are routinely recommended, although their availability, of course, does vary a lot, and tilt tables in particular are not widely available, although considering the commonness of this problem, perhaps they should be. So tilt table testing, which may include drug provocation, although not commonly, and may provide an opportunity for carotid sinus massage. Echocardiography is important, and then some form of kind of long-term ECG recording, Holter monitoring, or an event recording. This is what happens with tilt table testing. You put the patient on a table, tilt the table to 70 degrees, and it does help to identify patients prone to vasopressor syncope. Now, during the tilt table testing, you may feel tempted to carry out carotid sinus massage if carotid sinus syndrome, and I will discuss carotid sinus syndrome a little more detail shortly, if that is suspected, but it does carry a very small but definite risk of sudden death. So this is not a test to be carried out casually or carelessly. It has risks of stroke, and it has risks of prolonged asystole, and is absolutely contraindicated in known carotid artery disease if there's been a previous stroke or an MI in the last 3 years. 3 months, I beg your pardon. You massage one carotid sinus for 5 to 10 seconds. Do not occlude it if you can possibly help it, and in both the supine and upright position. And if that results in a systole for 3 seconds or more, or a marked fall in systolic blood pressure with reproduction of the symptoms, that strongly suggests carotid sinus syndrome. Electrophysiological cardiac monitoring tests are very important in trying to identify arrhythmias as cause of cardiac syncope. They are much better at picking up tachyarrhythmias than they are for bradyarrhythmias. But what has become available more recently is implantable loop recorders, which actually go under the skin. They're rather like a cardiac pacemaker in that sense, and they can sit there for a very long time, up to years, and they automatically will detect and record both brady and tachycardias, as well as asystoles, but they also give the opportunity, the patient an opportunity to record when an event has occurred. And between these automatic recording and the patient triggered recording are much better at picking up tachy and bradyarrhythmias. With this kind of spread, bradycardias much commoner than tachycardias as cause of async. Investigation yield of these different tests, around about 30% nearly, or 27% from per head tilt table testing. External cardiac monitoring around about 10%, and very different figures. Some of them very much from companies, and so perhaps less to be tested than to be trusted. Otherwise, most figures around about 40 to 45% for an insertable loop recorder, if it is available. What I would also want to stress from this would be the profoundly low yield of EEG and MRI scanning and CT scanning would fall into the category of less than 1%. These are not investigations that are routinely useful in suspected syncope, unless, of course, as in the case presented, there has been a secondary head injury. So let's just briefly then go over some of the individual conditions, starting with vasovagal or reflex syncope, which, as we've stressed, is by far and away the commonest form of syncope. It's often recurrent. 35% of patients will have at least one recurrence in the next 3 years. And it's called reflex syncope for a reason. And this does help to illustrate the pathophysiology, which we'll maybe pause to look at just very briefly. So what happens is that the trigger, whether it's pain or an emotional upset or the sight of blood, whatever, triggers parasympathetic signals out of the cortex down through the parasympathetic nervous system, causing a bradycardia and decreased and helping to block AV conduction, accompanied by decreased sympathetic activity, which leads to vasodilation. So those three things, bradycardia, decreased AV conduction, and vasodilatation, lead to hypotension. Now, so far, this is a relatively normal response, although maybe exaggerated in these individuals. But what is definitely abnormal is that the carotid baroreceptors respond paradoxically. They give the wrong feedback to the CNS in this situation and aggravate both the bradycardia and the vasodilation. And that's the principal abnormality, and that leads to a downward spiral in heart rate and blood pressure, and thence to the global loss of cerebral perfusion that we talked about, and syncope. And this is an example of what happens if you are recording during the attack, pre-syncopal spell, and the syncopal spell in a long period of asystoles, you'll see in this otherwise healthy 16-year-old. Now already, and of course, when you see these patients in the emergency department or elsewhere, they don't need any active treatment because they have recovered, but they do need advice, and in particular about how they might abort an attack during that pre-syncopal spell. And I think all of us know these things. They're physical maneuvers, lying down, lowering the patient's head, taking them out of the hot room if they're in a hot, crowded room. Physical maneuvers, very often successful at aborting an attack and preventing syncope at the pre-syncopal stage. What is much less successful are measures to prevent the pre-syncopal episodes in the first place, to prevent pre-syncope and syncope altogether. Education and avoidance of the triggering factors can, of course, help. Tilt training sounds attractive, we'll talk about that, and sounds as though it ought to work, but sadly doesn't. Diet changes, fluids and salt, sound as though in some ways they ought to work, they don't tend to. Drug therapy, possibly, but mostly not. Pacing, possibly, but mostly not. So with tilt training, you're actually trying to enhance their orthostatic tolerance to reduce syncope occurrences. And simply, you have a patient stand upright against a wall for 2 or 3 minutes a day, increasing by 5 minutes a day up until 30 minutes. And some initial studies actually quite strongly suggested that this might have a useful effect in preventing attacks. But then more controlled studies suggested this was placebo effect, that there was no real benefit, on top of which, in most studies, there's a very poor adherence. So attractive in principle doesn't work in practice. Different drugs have been tried to try and prevent syncopal episodes, fludrocortisone, beta blockers, to prevent paradoxical sympathetic effects. SSRIs have been tried, vasoconstrictors, mostly again, all unsuccessful, with the possible exception of midodrine, which in various studies has proved partially effective. Cardiac pacing, and given that ECG that I showed you of a long syncopal pause, asystolic pause, you think the pacing might well work, but study results again are not very encouraging in the main. In older patients and in those whose ECG monitoring does show long pauses, there can be a benefit, and the general consensus is that this can be considered as a therapy of last resort if nothing else is working and if attacks are repeated. Moving on, carotid sinus syncope. This is rare. It's an uncommon cause of syncopal attacks. And what happens here is that the sensory nerve endings in the carotid sinus wall, again, Dr. Mariella mentioned this, are abnormally responsive. And so there is a reflex increase in vagal activity and the decrease in sympathetic tone, again resulting in bradycardia and vasodilation, particularly with head turning or with a tight collar or patients leaning on their neck a bit like that on a desk, usually in individuals over 50. And it's very important to spot because this is one of the uncommon forms of syncope that is preventable and very treatable. Class 1 indication for cardiac pacing. And for those who know about pacing, and I would not claim to be amongst those, sequential AV pacing is very definitely better than ventricular demand pacing, with this really quite dramatic effect on recurrence of carotid sinus syncope. Orthostatic hypertension, defined as a drop in systolic blood pressure of over 20 or more millimeters of mercury, 10 millimeters or more of diastolic blood pressure, 3 minutes after standing, or again going head up on a tilt table. And this is again an important cause of syncope, as you saw from the initial figures, around about 10%, and is caused by vasoconstrictor failure, sympathetic failure. In most cases, there's no compensatory increased heart rate, and so the patient's cerebral circulation. It is important, although the definition is 3 minutes, it is important to carry out sustained testing, because in some individuals it can be, for reasons that we just don't understand, it can be delayed. And there are a variety of situations where this can occur. Drug-induced is very common, and the drugs that you might predict, you can see there, postprandially, volume depletion, and again we heard a little bit about that. Primary neurological diseases, Parkinson's disease, multiple system atrophy, postural orthostatic tachycardia syndrome, diseases that primarily affect the autonomic nervous system, or diseases that secondarily affect the autonomic nervous system, diabetic neuropathy, alcohol, amyloid neuropathy, HIV neuropathy. These are some of the causes of orthostatic hypertension. And in some cases, these can be prevented with education about speed of sitting up and standing up, just very simply. Tilt training may have a role in this situation, although again, evidence is lacking. Midodrine can be effective in this situation. Support stockings, very simply, can be helpful in preventing these episodes. So then on to the second major category of syncope, and the more serious and potentially life-threatening cardiac syncope. And this is either, as we said before, arrhythmic or structural heart disease. And important to spot because of this effect on mortality. 6-month mortality of over 10%. Cardiac syncope doubles the risk of death in individuals in age-matched cohorts. And these are some of the arrhythmias that can lead to syncope, and most of those will be familiar to you and have been mentioned already by Dr. Mary Ellen. And I've mentioned already, bradycardia amongst identified arrhythmias is much commoner than tachycardia as a cause of syncope. Long QT syndromes are worth pointing out and pausing a moment or two. They're through abnormalities of potassium channel, either acquired, mostly through drugs, or genetic, and their significance and worry is in the susceptibility that long QT syndrome gives you to polymorphic ventricular tachycardia, or torsade de pointe, as used to be called. There are concealed forms, which is very definitely, I would say, a postgraduate topic that I won't venture into. What are the drugs that can cause long QT syndrome? These are some of them. It's a constantly changing and upgraded list, but you will notice that some of these drugs are very, very commonly prescribed. So this is not a desperately rare condition. This is probably unnecessary because most of you, I'm sure, would recognize this. This is what an ECG of torsade de pointe can look like. What is the treatment? Well, suspicion and recognition are crucial, of course, and the emergent treatment is intravenous magnesium, and then also considering pacing to overcome bradycardia or pauses. Paradoxically, you might think isoproterenal can increase heart rate and shorten repolarization and rescue, if you like, these patients. Of course, drug withdrawal, if this is a drug-induced QT syndrome, is important. And then the other arrhythmias, bradyarrhythmias, generally respond to various forms of pacing, tachyarrhythmias, drugs, or electrical interventions blocking, ablating pathways when that technique, which is highly sophisticated, of course, when that technique is available. And these can all be very effective in treating tachyarrhythmias and preventing loss of consciousness. So there we are. In conclusion, syncope is common. I hope I've shown, we've shown that it's got many causes. Mostly it's not serious, but a significant, if small proportion of cases are very serious, and they therefore need proper assessment and careful and appropriate treatment. Potentially life-threatening causes are rare, but these are successfully preventable once you do find them. And with the commoner ones, it's the other way around. They're not life-threatening, but in fact, vasovagal syncope is much harder to prevent. So I'll stop there. Thanks very much again for the opportunity to join the symposium.
Thank you, Professor, for the wonderful presentation. We shall only take one question from the chat by Rachel to Professor. Professor, what's your take on the rise of young people collapsing since the rollout of COVID vaccines? That's a question from the Q&A.
Gosh, no, that's a good question. I'm not sure that I have an explanation. Of course, any injection of any vaccine, a bit like any venesection, can, in susceptible individuals, serve as a trigger for vasovagal syncope. And those of you who've worked in vaccination clinics will know that it's not a rare event for a healthy individual. And I would have to say more commonly a man than a woman, although syncope as a whole is commoner in women. But I think this type of syncope, pain-induced, is probably commoner in men to collapse in your vaccination clinic. So it may be that the vaccination on a scale that we just hadn't seen before globally with COVID vaccines has simply brought out a susceptibility for injection-induced syncope. Whether there's a more sophisticated explanation or that than that, I'm not aware. I don't know whether Dr. Mary Ellen has seen a lot of this in the first instance, and whether there's an obvious answer that I've missed that she would reveal. I'm not sure.
No, I'll just say that, I mean, are you asking about people who pass out at the time of the injection? Because if that's the case, I will say it is very, very common to have an episode of syncope during an injection of any kind or a blood draw. It's why, you know, you have to sit down when they do it, and they have chairs with arms. And so I agree that I don't think that there is, to my knowledge, any evidence that a higher number of people are passing out during a COVID vaccination than any other injection. It's just that for the first time in living memory, we're trying to inject everyone in the world with something, and consequently are seeing what is already very, very common, which is passing out when you get a shot of any kind. We're just hearing about it more often because everyone we know is getting a shot at the same time. So that would be my take on it.
Thank you, Dr. Mary. We shall have the next presentation about nursing care and discharge precautions by Ms. Dorothee. If you're online, please, you're welcome to share your screen and start the presentation. In the meantime, keep your questions coming in through the Q&A.
Good afternoon, everyone. Am I audible?
Yes, you're audible.
Am I audible?
Yes, Ms. Dorothy, you're audible. We can't hear you.
All right. All right. My presentation is not long. It's just very tiny thing. Where is it? Good afternoon, everyone, again. I decided to focus on one source of the syncope. Where am I again? Yeah. I hope you can see my screen.
Yes, we can see your screen.
All right, so I decided to focus on the cardiac source, even though I'm going to speak about the other source as well of syncope, because it's not easy to do a nursing care or something that is not know what causes it. So I just decided one point, and then I'll talk about the other side as well, based on what the discussion has been earlier on. All right, so as Dr. Elaine and Prof mentioned just now, we have three main categories of source of syncope. We have our vasovagal source, we have our neurovascular source, and then we have our cardiac source. So depending on the one that has been found as being the cause of the patient condition on the scene or in emergency room or unit, the nursing focus kind of becomes simple. If it's vagovasal, so then it will be easier. You know that your patient is more reversible and is probably, like we spoke earlier on, is maybe emotional, it's maybe easy to treat. Maybe we'll have education only or diet change, and then the patient is back. Maybe the patient also won't need admission into medical ward or an ICU. So the patient will be discharged. So that will be most easy to deal with. But then if we have a cardiac source of a syncope, now depending if it's arrhythmia or structural heart issues, again, that will again change the nursing care plan, because you'll have to look at the patient coming probably to a specialized unit, not just in a medical ward, but maybe a unit like an ICU or an HDU, depending on what's available in the different areas. Then the patient might be going either for a surgery to correct the issue if it's found to be structural. If it's electrical, maybe the patient will go for insertion of a pacemaker to correct the arrhythmia. So depending of what exactly the cause is, so you have to think about all of that as the nurse, and then prepare for it, prepare for whatever it is. Syncope is found, the nursing team should bear in mind the possibility of recurrence. Then you have to think about things like possibility of falling.
In emergency handling, you don't need that I am smart or what. If it means you bending,
right? Like I said earlier, in an ICU or HU, as soon as office syncope is localized.
Have to do so. It's all about someone saying.
Patient should be placed on a continuous cardiac monitor. Patient should be monitored for possible rhythm changes. If possible, daily or bi-daily ECG if the syncope has a cardiac source, again, to be able to detect any change in rhythm and then be able to act upon it earlier enough. So we don't want to wait when it's too late and then you can't reverse anything. Certain way, if I can, let's say in the medical world, we have to think about possibility on bed rest.
Well, we've lost Miss Dorothee. We're just going to wait for a few minutes and see if she can reconnect. In the meantime, keep the questions coming in to the panelists, and we shall answer them as soon as we can. So we've moved to the Q&A. In case you want to ask a question, you can raise your hand and we shall give you the mic. From the Q&A, we have a question from Miss Joanita to the panelists. The question goes, does exercise reduce or aggravate the risk of syncope?
Does exercise reduce or aggravate the risk of syncope? I would say that exercise doesn't really affect the risk of it in general. There is such a thing as, exercise-induced syncope, but it's not that if someone with, perfectly normal, healthy physiology exercises, they're going to have syncope. It's so it's not something where the syncope is a risk factor for where exercise is a risk factor for syncope. It can be a cause of it in some, a fairly rare cause of it in some people. In general, exercise is good for you, right? So in general, anything that makes you, happier and healthier is a good thing, but I would not think of exercise either as a risk for or a preventative for syncope. There's not really a causal relationship that way, unless Professor Scolding has a different take on that.
Absolutely not. No, I completely agree. Yeah, completely agree with all you said. Yeah.
Then we have a second question from Mukisa Joseph. Can people with a history of vagal syncope watch horror movies? Professor, what's your take on this?
Well, if they want to.
Yay!
I don't think it's a contraindication at all. If being deeply frightened is a clear stimulus in one individual's case for a syncopal episode, then they might be well advised not to. But ordinarily, I would say watch as many movies as you like. Although, to echo Dr. Mary Ellen's point, they'd be much better off getting some exercise.
Yes, I mean, syncope itself, particularly like as vasovagal, is not dangerous. There are people, as I say, who tend to faint every time they get a blood draw or anything like that, which doesn't mean that they don't have to have their blood drawn sometimes. It just means that they make sure to be sitting down when it happens and prepared if it happens. So certainly, if somebody tends to pass out when they get scared, but they love horror movies, I say, watch them on a soft couch.
So anyone with a question from the audience, please raise your hand.
Oh, we have one. Let's see, who is that? I can't see who. Oh, James Opio.
James Opio, please go ahead.
Good evening, and thank you so much for the presentations. My concern is about the lack of emphasis on imaging. You realize to this point, we've only talked about CT-MR, and as you know, these are high-end imaging modalities, which are not so readily available, and if anything, they are also quite expensive. And most importantly, it looks like we're going to use them to rule out head injury, like after someone has had a syncope. To my knowledge, there are imaging modalities that can be used by the bedside. This time not to look for complications, but to test for the possible cause of syncope. To this point, I want us to think about bedside echo. That can help us to detect structural heart disease like aortic stenosis, hypertrophic cardiomyopathy, even PE. We also need to talk about Doppler examinations like carotid and vertebral artery Dopplers to detect plaque. And we can also do transcranial Doppler to assess for vertebrobasilar insufficiency, which are also causes of syncope. It's just that I wanted us to have a bearing that there are the bedside imaging tests that we can do other than just CT and MR. Thank you.
Thank you so much for the contribution. So we have another.
Yes, nice to speak to
Yeah,
that.
please.
I 100% agree. I mean, certainly as an emergency medicine doctor, and we are all about point of care ultrasound. I agree. I should have more clearly indicated that. I was operating on the feeling that it is not available, widely available. And so it's more likely when I say if you find if you have a concerning history or exam and you pass them along for further care, but absolutely bedside ultrasound to do an echocardiogram to look at the heart and see, is there signs of that hypertrophic cardiomyopathy? Are there signs of right heart strain to suggest a pulmonary embolism? You can actually do a DVT scan to see, does this patient have clots in their legs, which would suggest the PE? So you can look at the aorta. So absolutely, point of care ultrasound can be extremely helpful in differentiating causes and specifically looking at some of the more concerning causes of syncope. And I look forward to the day where every acute care or emergency department has a bedside ultrasound probe to do that.
Thank you so much.
So we had another question. Any attribution of deity to syncope to our panelists?
Not that I know, Professor Scolding. I mean, there is the postprandial, the post big meal syncope that can happen, but
Yeah.
I'm not aware of any dietary, like food choices that will make you more or less susceptible to syncope, though unless I'm.
No, I'm not aware of any. I'm not aware of any. No, it's quantity rather than quality, as you say.
Right.
Too much can trigger, and fasting for a long period can be a trigger in some individuals for syncope. But types of food, there's nothing, at least that I'm aware of.
So the other question is how can you differentiate between syncope and malingering from the chat?
Well, malingering meaning someone who is. Go ahead.
Professor, go ahead, please.
I suspect we're going to say the same thing. Malingering is actually very uncommon. Functional causes, behavioral causes for possibly deep-seated psychological reasons are rather less rare. And in my experience, they can sometimes be extremely difficult to distinguish. Of course, making a diagnosis of malingering or making a diagnosis of a functional or hysterical, whatever you'd want to call it, blackout should be the last thing on your list of differentials. It is important not to miss it, but it's far, far more important not to mislabel somebody as malingering or mislabel them as having attacks of psychological origin. It can be very difficult, and that is where I think it does become important to make sure that you're doing an ECG, that you're doing an echocardiogram on patients when there is any doubt. I don't know whether you would say the same, Dr. Marianne, or whether
Absolutely.
you have
Absolutely.
tricks in the emergency department.
No, and I would remind people that malingering is specifically when someone is deliberately trying to give the impression of an illness of some sort for a secondary gain because they want to get an insurance payout or they want to get out of going to jail or something. Although I will say it's very rare in my experience with my patients who are prisoners. I think people are a bit too quick to assume that a prisoner is malingering when they actually have real pathology. But there's all kinds of psychogenic reasons for syncope that people are not doing deliberately. Reasons that some part of their brain tells them, has them have a syncopal episode but that they're not doing deliberately. It's very difficult to distinguish. In the acute care setting, we really just need to make sure it's not one of the immediately concerning things like the cardiac causes or or the more concerning neuro causes. But it's why, in general, I always suggest people follow up with their doctors, and particularly if they have a history of it, because there may well be some psychological issues that would benefit from further outpatient workup. And if you're worried about a patient for any reason, including psychologically, keep them, admit them, or transfer them for a higher level of care. Certainly our psychiatric colleagues are part of inpatient medicine as much as anyone.
Eric, please, you can unmute and ask your question. Marwin, Eric.
All right. Yeah, thank you so much for a quite informative session. I just want to follow up question on carotid massage. I think Professor emphasized that it shouldn't be done in uncontrolled environment. Yet, in situations, these maneuvers or these first initial steps are quite important. For example, in a non-sustained VT or SVTs, and people come in and they have episodes, they are quite important steps to use to avoid such kind of situation. Are you telling us that these sort of maneuvers can only be done in specialized environment or by specialists? Is that the point? Thank you.
No, I'm absolutely not saying that. What I'm saying is that in the routine assessment of a patient who has had a syncopal episode, that using carotid sinus massage as a diagnostic test is hazardous, potentially hazardous, and should not be done casually. It can be done, but in controlled circumstances. And it is absolutely a very different case to using carotid sinus massage as a therapeutic, not a diagnostic, as a therapeutic maneuver in a patient with a narrow complex tachycardia. They're very, very different clinical situations, and I think it's very important to make that distinction. It remains a very valuable therapeutic maneuver, and yet again, I would say, something that Dr. Mary Ellen would know far more about than me as a neurologist.
Yeah, and we in cases where if we're trying to break someone's supraventricular tachycardia, for instance, or their AV nodal reentry tachycardia, we think sometimes of carotid massage. We never do it bilaterally, right? We don't want to cut off the blood supply on both sides of the neck for obvious reasons. But the important thing there is you always listen for bruits first. What makes it dangerous is if you have someone who has blood vessels, as a lot of humans do as we get a bit older, that have fat, a lot of lipids there on the inside. If you start pressing on those vessels, you can break off a piece of that and cause a stroke, right? So you want to listen first for any bruits. If you hear that sort of bruit in there, this suggests that there's some clogging in those vessels. Don't touch them. Okay, just don't touch them, right? You don't want to break anything off and send it into the brain. If you don't hear any bruits in the neck, and especially if you have a young patient that you would not expect to have a clogged artery at that point, then sure, a unilateral carotid artery massage to induce vagal tone, absolutely can be done.
Thank you, Dr. Mary. Please, there is a post-test going on, and hope most of you have been able to reply or answer. I would like at this moment to invite Thomas. Dr. Thomas, would you like to come and give the closing remarks?
Thank you so much, Dr. Semakula, for the session. We are happy to have had a good number of you from the start of this phase until the end of this phase. So the phase has ended. The phase has had 14 session, and out of the 14, today is our last session at the end of the fence. And we are happy to we had, I think, around 360 and over among the people who registered for today's session. We shall do the coming session in 2 or 3 weeks. We are going to keep you updated on your emailing lists, and those that want to join the group, we have a WhatsApp group where we post many of the information that regards the echo sessions. The people who are eligible for the certificates, like we said on today's registration link, are the people who attended at least 8 of the 14 sessions, and we are looking for the best way to really award these certificates. One of the ways we thought it would be a golden certificate, but we went to the market and gold was expensive. So we are going to see how best we can award the certificate, but we are happy. And if you have any questions regarding EMS echo sessions and React teams, reach out to us, to any of those emails that you use that send you email invites. And as well, you can reach out to any of the other people who are the React coordinators in our different facilities. Other than that, I want to wish you a very nice weekend. And since this is the last session under this phase, which has run from, I think should be around May up to now, would like to take our screenshots. But as we take screenshots, let us respond to the session general assessment. This is the last assessment we're having under this phase. So you can give us the best reviews, or you give us the reviews according to how you feel the session went. Thank you, and we'd love to see all of you on camera. Back to you, moderator.
You can, at this moment, you can turn on your cameras if you're comfortable for the screenshot. I would like to thank our experts, Dr. Mary and Professor Scolding, Miss Dorothee, and Dr. Kizito Prisca for sparing time to make this session quite informative. Thank you so much.
We can have some comments from our participants. If you have any comments about the echo sessions, how best we can improve them, please raise your hand and the moderator will choose you as we go ahead and take our end of phase screenshots.
Thank you very much. Thank you very much. I've not been able to do the pre-test and the post-test. I'm trying to access them, but I've failed to do because they're not appearing. I'm not able to do them. And I don't know.
They're generally found if you, on the bottom of your screen on the right, where it says more, you have to hit more in order to find them. Of course, they're only available during the time they're available, but you have to kind of look for them.
Just go to more and look for polls and quizzes. Then Namukoza, please go ahead and unmute.
Good afternoon, everyone. My question is going out to either you guys or you help me like pass on the information to the responsible body. I've never gotten my CPD points from ECHO ever since I started attending this session, even though I register. And I think it's happening for many.
Yes. Are you a member of our ECHO WhatsApp group?
No.
Okay. There's a WhatsApp group that I believe is the link on the chat today.
Yes, we have a link that we post on the chat. Please, you ensure that you fill in your details during the session when you attend. The links change. Registering for the session does not automatically translate into getting the CPD points because we have many people who register and they do not attend. So you respond through that. Shall capture your details for nurses. We have nurses and midwives who just received the guidelines from the Nursing Council. We're going to compile all our backlog and then submit to the Nursing Council. But for doctors, we do it every after a session. Your points should reflect. If your points do not reflect, or if you do not have a way to access your points, you go to the council and you get them to activate your online platform where you'll be able to access your points. But for nurses and midwives, we are going to upload all our backlogs. For the allied health, we got a challenge with the council. The council has internal issues that it's addressing, so it's not taking on any external requests for now. So that's out of our control. When that is out of the way, we shall be able to slot in our application and we're able to award the CPD points. So the link to the WhatsApp group, it can be shared by the React coordinators, and you can also capture your details.
Can we put the link in the chat?
So we're going to put the link on the chat in a few seconds. But as we do that, Dr. Prisca, Professor Scolding, any closing remarks, and Ms. Dorothee?
Nothing very specific from me. I've enjoyed the session and I hope it's been worthwhile. It's a really good forum, and I congratulate you and the organizers of ECHO. We had, as you said, we had 370, 380 people at one point. I think it's a fantastic achievement, so very well done to you.
Thank you, Prof.
Yeah, I would just say I also love this and the participation that everyone makes. My passing thought is, if the patient that I always keep in mind that I had when I was working at the Veterans Administration back home, it's an organization that specifically takes care of our military veterans and gets an elderly population as such, a very tough elderly gentleman, as you can imagine. And I had one time who came in for hip pain. And when I went to the room, I said, "So what brings you in today?" And he said, "Well, I fell asleep in the lunchroom." And I said, "What?" And he said, "Yeah, I was sleeping in the lunchroom until they brought me over here." And I said, "Okay, you took a nap in the lunchroom?" And he said, "Well, I guess I was eating lunch." And I said, "So you were eating lunch and then you what?" And he said, "I woke up in the wheelchair and they were wheeling me here." And so that was a case of syncope at rest, right? He was eating lunch and woke up in a wheelchair because people noticed that he slumped over while seating. And when we did at bedside ultrasound, as our colleague suggested, he had tamponade. We ended up draining 1 liter of fluid from the sac around his heart. So I always remember that patient, to remember the importance of the history, right? The chief complaint said hip pain because it was hip pain that made him come to the hospital that day. And then he decided to get lunch first, and then he passed out while he was sitting there. And if I just went in and took care of his hip, I would have missed the fact that he was about to die from a critical cardiac rhythm. So the importance of a history and physical exam is easy to forget in these days of technology and everything else, but never underestimate the power of a careful history and letting patients tell their story in their own words. Don't just fire questions at them. Ask them, "Why are you here?" and then shut up and listen.
Thank you, Dr. Mary. We have a hand from Najiwa Namusoke. Please unmute and go ahead.
She already asked. She already asked.
Oh, thank you.
I had already asked. I just forgot it up.
All right, thank you. Back to you, Thomas.
Thank you so much. I have shared the link to the WhatsApp group. Please click on the link and join the group. We may not be able to add everyone individually, but if you click the link, you will automatically join. And right now, I've had over 20 people join, so I still have space for about, I think, 200 people, since the group has already 900 participants. Outside that, we'd love to appreciate you once again for participating in the EMS Echo sessions, and would want to wish you a nice weekend. Please practice what you've learned, and share your knowledge with others who are not able to attend. Have a good weekend.
We'll see you soon.
See you soon.